Respected chairpersons, delegates, good morning everyone. So basically this is iron discussion on iron therapies in heart failure. So far we have discussed about the heart failure with reduced ejection fraction. So this talk will be on heart failure with preserved ejection fraction, how iron deficiency affects and how this study is done. My talk is based on PREFERHF trial, that is pragmatic evaluation of ferritin in heart failure. So as we all know, heart failure with the preserved ejection fraction burden is increasing and it is associated with poor outcomes. So the major drivers for heart failure with preserved ejection fractions are increasing age, diabetes, and obesity. And as we all know, it is associated with high rehospitalizations and impaired quality of life. And 1 year mortality, if you look at, it's about 5 to 15%. So if you look at the prevalence of iron deficiency in subset of heart failure with preserved ejection fraction, it's about 50 to 70% across all the registries. It is especially more common in women, diabetics, and CKD patients. It is linked with poor exercise tolerance and rehospitalization risk. So if you look at the pathophysiology of iron deficiency, iron is central to the mitochondrial oxidative phosphorylation and ATP generation. And as in heart failure with reduced ejection fraction, reduced peripheral oxygen utilization is amplified by the iron deficiency. So it augments the oxygen utilization deficiency, leads to skeletal muscle dysfunction, fatigue, and reduced exercise tolerance. This is the main problem. So we attribute this to general heart failure itself, and we ignore the part of iron deficiency in contribution of iron deficiency in managing this type of presentation. So iron deficiency contributes to systemic inflammation as well as impaired cardiac energetics. And if you look at this figure, there are various trials or various drugs targeted at the mitochondrial level to address these issues. Coming to the observational and registry evidence, here compared to heart failure with reduced ejection fraction, all the guideline-directed therapies or all the available therapies are underutilized in subset of heart failure with preserved ejection fraction. So this highlights the underutilization of GDMT in heart failure with preserved ejection fraction patients. And this slide was described earlier. So iron deficiency is 60 to 70% prevalent, and it is associated with worsening of Kansas City cardiomyopathy quality scoring as well as 6-minute walk distance, and it is associated with higher early mortality and rehospitalization rates. So coming to the trial proper, this is a screening period for about 2 weeks. So inclusion criteria was like chronic heart failure with ejection fraction more than 45%, stable ambulatory NYHA class 2-3 patients were included, and treatment with a diuretic, one of the following, like hospitalization for heart failure in last 1 year, and raised natriuretic peptide levels. If patient was in sinus rhythm, so NT-proBNP cutoff was more than 300. If patient was in AF, NT-proBNP cutoff was more than 600. And BNP cutoff was 100 for normal sinus rhythm patients. And whenever patient is in AF, that was BNP cutoff was 200. And 6-minute walk distance less than 450 meters patients were included, and hemoglobin between 9 to 14, and presence of iron deficiency as described in trials with heart failure with reduced ejection fraction is the same. Ferritin less than 100 nanograms per ml, or if ferritin is between 100 to 300, and then comes the TSAT less than 20%. So this is the inclusion criteria. And the intervention period was about 52 weeks. The primary target, like 6-minute walking distance, measured at 24 weeks. there is a, they have done 1:1 randomization. So what is the main important about this PREFERHF trial was there were no prior RCTs before this trial in the subset of heart failure with preserved ejection fraction. And heart failure with reduced ejection fraction trials consistently showed symptomatic benefit in quality of life and 6-minute walk distance. And PREFERHF designed to test in subset of heart failure with preserved ejection fraction. So this is the trial design. So total 74 patients are studied. So among them, some patients like 32 patients, 34 patients dropped, and 40 patients they have taken finally, and 22 patients in FCM group, and 22 patients in a placebo group, and 18 patients in trial group. And they have done the trial for about 24 weeks and continued for 54 weeks. So this is the design. It's a randomized double-blind placebo-controlled trial. Population screen was 74 and 49 randomized. Eligibility, as we discussed, ejection fraction more than 45%, NYHA class 2 to 3, and elevated pro-BNP, more than 300 in sinus rhythm, more than 600 in AF patients, and reduced 6-minute walk distance less than 450. And iron deficiency, as we discussed earlier, like ferritin less than 100 or ferritin between 100 to 299 with TSAT less than 20%. And follow-up period, primary endpoint was 24 weeks, and the trial extended up to 54 weeks. So primary endpoint looked was change in 6-minute walk distance at 24 weeks. So if you look at the baseline characteristics, this is a very small group, high risk heart failure with preserved ejection fraction patients. Mean age was 74 years, and 60% were female, and mostly in class 2 to 3. Comorbidities are like high rates of hypertension, diabetes, and atrial fibrillation. Iron parameters, like median iron level was 70 only, and TSAT median was 18%, and functional 6-minute walk distance was between 300 to 320 meters. So primary endpoint was, target was to check the 6-minute walk distance at 24 weeks. So results with FCM, there was 49 meters increase from the baseline, and whereas with the placebo only 15 meters increased in walk distance. So the effective treatment was 34 meters increase in walk distance with the FCM therapy. So clinical meaning exceeded minimal clinical important difference, defined as 30 meters. So here they have achieved 49 meters. Then it confirms functional capacity improvement with IV iron and heart failure in heart failure with preserved ejection fraction. So this graph clearly shows that till 24 weeks and even up to 32 weeks, there is a consistent increase in 6-minute walk distance with in the trial group. If you look at the secondary endpoints like KCCQ score and all quality of life measures, significantly improved with FCM at 24 weeks. Consistent effect across all domains like symptom frequency, physical limitations, quality of life, all those improve. And EQ5D score positive but a smaller gain versus placebo. NYHA class, they noticed that a shift towards a lower class with FCM. And biomarkers like NT-proBNP, ferritin, TSAT confirmed correction of iron deficiency. No safety signals were documented. This graph clearly depicts 6-minute improvement in 6-minute walk distance as well as other parameters. Coming to the safety outcomes, no significant difference in liver or renal parameters like alanine transaminases, gamma glutarate transaminases, creatinine, blood urea nitrogen, all were studied and everything was same compared to the placebo group. No new safety signals compared to heart failure with reduced ejection fraction trials. And it confirms IV FCM safety profile in heart failure with preserved ejection fraction. So what were the common events noticed during the trial was hypersensitivity. As we all know, iron injections carries this risk of hypersensitivity, and some infections and some of the patients developed AKI. No excess risk versus the placebo was noticed, and it confirms again IVF's safety across all heart failure phenotypes. Coming to the summary, so quality of life and functional endpoints improved, and safety consistent with prior randomized control trials done in heart failure with reduced ejection fraction. Mortality and rehospitalization is like other trials, it's exploratory only. No clear-cut benefit in terms of mortality reduction. So coming to the strengths of this PREFERHF trial, it's a first dedicated FF trial with IV iron therapy, a robust placebo control design, focused on patient-centered outcomes like quality of life measures. Coming to the limitations, it's a very modest sample size, only 70 patients were taken, and underpowered for mortality and hard outcomes. And heart failure with preserved ejection fraction is, group is very heterogeneous in terms of obesity, AF, CKD. So we cannot generalize these outcomes for larger population. So coming to the comparison with HFrEF trials, so FAIR-HF2 trial tested hard outcomes like mortality and rehospitalization, and AFFIRM AHF, Ironman, and HeartFit reduced hospitalizations neutral for mortality. Again, similar with this trial, PREFERHF is also showed clear-cut benefit in terms of functional and quality of life improvement. Mortality gap is persisted. So in conclusion, HFrEF trials established hospitalization benefits. Heart failure with preserved ejection fraction trials confirm functional gains, but outcome gap remains still the same. So subgroup data of confirm HF effect, HF registries, other meta-analysis, compared to other meta-analysis, these are the main meta-analysis done, like Mind, Wang, and Ahmed. All these data, all these meta-analysis supports IV iron therapy, and HFpEF specific pool data limited. So this is an attempt to overcome that gap in FF subset. So coming to the clinical implications from this trial, IV iron improves quality of life and exercise capacity in FF, potentially complements SGLT2 inhibitors and ARNI and lifestyle intervention in this group of patients, and therapeutic option in symptomatic iron deficiency positive FF subset. Coming to the India-specific lens, as discussed by earlier speakers, so there is a huge gap in Indian subset for iron deficiency treatment, as well as for identification of iron deficiency itself. 60 to 70% of prevalence was noticed. Women, diabetics, and CKD are disproportionately affected with this dreaded complication of iron deficiency. So what are the main barriers is like awareness. Awareness not only among the patients, among the physicians also. As discussed by previous chairpersons and all discussion, it's awareness about the iron deficiency as a subset, as it affects the quality of life in our patients. So we have to create awareness among the physicians and patients as well. And infusion access, like some clinics should be dedicated, clinics of iron therapy should be available in heart failure centers. And as shown by my previous speaker in one of the slides, it's cost effective. Coming to the future direction, so larger outcome powered RCT is needed in heart failure with preserved ejection fraction, like heart failure with reduced ejection fraction. And pragmatic registries in India needs to be done. And integration of IV iron into heart failure with preserved ejection fraction guidelines once outcome data is available, and it's coming to the key takeaways. Iron deficiency is common and clinically relevant in heart failure with preserved ejection fraction. PREFERHF shows functional and quality of life benefits are confirmed in this trial. Mortality outcomes remains uncertain. and IV iron therapy is safe, feasible, and relevant to Indian practice. So iron deficiency is not just a biomarker, it is a therapeutic target with early RCT evidence. And PREFERHF opens the door for larger outcome trials. And for India, it's time to recognize iron deficiency in HFpEF subset. Thank you very much.